Ladies and gentlemen, dear Chairman Stefan Brocha, it's a true privilege on behalf of the task force to present this first presentation on the acute handling of the patients with an ST segment elevation myocardial infarction. And if you take the chain of survival of patients with a STEMI, you will see that I will cover the first three circles and remain with the last circle for the other speakers. So I will take also the time for the first three circles to handle with. We all know that it starts with the onset of the symptoms and then the way how the patient will present either to a PCI center, a non-PCI center, or the first access to medical care is in the outpatient center setting with the EMS team. So the first medical contact is now clearly defined in these guidelines as a first contact to either a physician, a paramedic, or an EMS, a trained EMS worker, and then go on to the definition of an MI. In order to come to the definition of an MI, we consider that, of course, you need a 12 leads ECG. It can be a standard ST segment elevation myocardial infarction, but we also consider in these guidelines that there might be different presentations, like left bundle branch block, right bundle branch block, ventricular paced rhythms, isolated posterior myocardial infarction, or ischemia due to left mains disease or severe multivessel disease, the so-called Wellens criteria. We acknowledge that these presentations might be there, and we advise people to handle patients with atypical presentations as if they had an ST segment elevation myocardial infarction. So the rest of the guidelines would also apply to them, specifically according to the clinical presentation and even the atypical ECG. Left bundle branch block, right bundle branch block, we don't make any distinction anymore. They will be handled in the same way. Is there room in the hospital for additional imaging criteria? Yes, there is room for echo, but not on a routine base. There is room for echo in specific settings if there is some doubt on the diagnosis. So if the diagnosis is uncertain, there we put should be considered next to the echocardiography. If you handle a patient with an acute myocardial infarction, the first question that comes up, should we use routinely oxygen? So the answer is already provided by Stefan. No, not on a routine base. Yes, for patients that remain hypoxic. And there we lowered the threshold from 95 to 90% for these patients based on the detox and the avoid trials. Also, there is a change in the use of the recommendation for use of morphines or opioids in this patient population. There we downgraded the recommendation from 1 to 2A. And this is based on the data that are provided that potentially morphine derivatives might interfere with the absorption and the action and the onset of action of dual antiplatelet therapy. Indeed, we acknowledge the work done by the previous guideline committee in establishing the time to intervention. As Stefan was already alluding to, we avoid now the terminology door to balloon, and we want to be more strict and more clear on what we intend to say. So indeed, the 120 minutes time frame remain, but then we say exactly where we're aiming from, and this is the wire crossing. Also, if you would aim for a fibrinolysis strategy, we clearly depict that the time frame from diagnosis to start of fibrinolysis should be 10 minutes. STEMI diagnosis is based on an ECG. It's not the first medical contact that lets the clock start ticking. It's the diagnosis of STEMI that lets the clock start ticking when approving or when assessing the time frames needed to adjust your strategy, either fibrinolysis or either PCI. Important as well is that for patients sent to fibrinolysis, And later on, routine PCI strategy afterwards, there we also are clear on the time frames where we want to see this additional PCI strategy to be established, and that's between 2 hours and 24 hours. That's also an aspect that is new in our guidelines. If we are confronted with a patient with heart failure after an ST segment elevation myocardial infarction, we more or less remain with the previous guidelines, but we make a clear statement on the need of patient intubation or non-invasive mechanical ventilation. We know and we remain with the previous guidelines on the use of intravenous nitrates or sodium nitroprusside in this patient population, but again, and I point again to the fact that we downgraded the use of opiates, so morphine derivates, also in this patient setting in order to tackle anxiety or even the feeling of congestion in this patient population. There we took it down from a 1C to a 2B recommendation. It may be considered, but certainly not it is recommended. The same thing is true for the use of inotropic agents. We all know that it serves to the best interest of the patient in certain patients, but we all know also that the use of these type of drugs have also the counterbalance effect of a potential influence of mortality. If the patient is admitted for cardiogenic shock, we remain with the previous recommendations that indeed the patients are sent for a revascularization strategy, and we introduce also here the concept of the heart team, as was done in the revascularization guidelines. What is new, and we think what is important, that we put again fibrinolysis next to PCI also in this patient population. We don't have any data not to do that. And we stick to the concept of complete revascularization. And that's why fibrinolysis appears again in the current guidelines in this patient population. Intra-aortic balloon pump on a routine base in this patient population will become a class 3 recommendation, and it should only be considered in specific patient populations with mechanical complications due to the myocardial infarction. If the patient is admitted with acute heart failure, we also acknowledge the use of ultrafiltration, but we bring down the grading from a 2A should be considered to a 2B may be considered. The same thing goes so for the inotropic agents, and for the short-term mechanical support remains on the same level. As I told already, routine use of the intra-aortic balloon pump is no longer advised due to potential adverse events. So in a nutshell, for the acute heart failure and cardiogenic shock, from the left-hand side to the right-hand side, you can see and appreciate the changes that we introduced into the current guidelines. Patients in cardiac arrest, indeed also for these patients, we will stick with the previous guidelines. So therapeutic cooling is there, and also primary intervention strategy is there. Not only for patients that are admitted with a clear ST segment elevation myocardial infarction, but we also consider this strategy in patients where the criteria might be less clear. So there also, if there is any clue towards the fact that myocardial ischemia may have been the cause of the cardiac arrest, we advise to send the patient to the cath lab. It should be considered. If we then switch to the arrhythmias, there we want also to be a little bit more clear than the previous guidelines. In patients admitted with atrial fibrillation next to a myocardial infarction, we advise to use beta blockers in the first line. Alternative might be amiodarone, but as you can appreciate, digitalis is put on a lower level. Of course, if the patient is hemodynamically unstable, cardioversion should be considered. If we want to cardiovert the patient towards sinus rhythm, we stick with amiodarone. We abandon the use of beta blockers, digitalis, or other drugs in this setting. What is new also for these guidelines is that for patients admitted with an acute myocardial infarction and complicated with atrial fibrillation, that there is a recommendation at least to consider the long-time use of NOACs in this patient population. If we are confronted with ventricular arrhythmias or conduction disturbances, to this point we remain with the previous guidelines. A new element that we also introduced in the current guidelines is that in patients that have persistent ventricular arrhythmia in the setting of a myocardial infarction following revascularization, that also the help of an electrophysiologist should be considered, and that radiofrequency catheter ablation is a therapeutic option as to the current task force. In patients with recurrent VT, with hemodynamic repercussion, despite repetitive cardioversion, they may be treated also with beta blockers, amiodarone, and overdrive pacing. We strongly advised against the use of prophylactic treatment with arrhythmic drugs in this patient population. Also, we caution against the asymptomatic and hemodynamic irrelevant ventricular arrhythmias. Also there, we caution against the use of antiarrhythmic drugs. I want to end my part of the presentation with the oversight view that was also provided by Stefan, that we indeed point clearly to the element of the first medical contact, that STEMI diagnosis starts at the moment of the ECG, that the selection of PCI over fibrinolysis when anticipated delay of STEMI diagnosis is more than 120 minutes, this concept is abandoned. Also in this patient population, we consider fibrinolysis to be an option. Important as well is that left-banded branch block and right-banded branch block as an atypical presentation of a myocardial infarction are considered in the same way, and we advise to treat the patients accordingly in the same way as you would treat an ST segment, patient with an ST segment elevation myocardial infarction. The time frame for these patients to get to additional PCI is set between 2 hours and 24 hours. Thank you very much.